with that skill and knowledge, this is kind of a sidetrack because just as you're mentioning
Mm.
it, I was just thinking about
Yeah.
this, and you mentioned this term. You guys sit at the top of the diagnostic tree, and I was actually
Mm.
thinking about this the other day. And now we're going completely off topic, and I'm going to give a long story. But me and my wife were rewatching Scrubs, and we're watching the
Oh,
first
yeah.
season.
It's a good show. I like it.
And in the first season, there's this episode halfway through. Maybe it's the first season or second season, but there's this episode where JD has one patient who is Dr. Cox's best friend, and it's the episode where he gets
Oh, is that
diagnosed.
Brendan Fraser? No.
Yeah, yeah. And spoiler
Oh, it
alert,
is.
yeah. And so he gets diagnosed with leukemia, and
Yeah.
this episode revolves around essentially JD grappling with the fact that maybe there's a mistake made in the blood work that's been done that's led to this diagnosis.
Oh,
And
yes.
so he
Yeah.
goes
Yeah.
through multiple phases where these errors could be made, and he ends up finally going to the final person that makes that decision, who's the pathologist. And I think the pathologist's name was Dr. Bob or something. He had like a first name for a last name as a joke.
Yeah.
Um, and the reason I bring this up is he asked the pathologist, has there been a mistake? And the pathologist says, do you want there to be a mistake, or are you just hoping that I made a mistake in terms of you don't want that
Great
result to
one,
be,
mate. I really like
yeah,
that.
and you don't want that result to be true. And it got me thinking about, in a weird way, stress with decision making. And it's something that's unique, not in my specialty. There's specialities in medicine, such as radiology, pathology, where the stress is made from definitive decision making compared to the luxury that sometimes we have that we don't realize in, say, a general medicine specialty or intensive care or ED, where, as you're saying, the patient is in front of us. So we have the ability to make a decision or a clinical decision, see what the response to the clinical decision is, and then reassess and then remake another decision based on that. So we have the ability to
Mm.
swap and change a treatment pathway multiple times. But when it comes to these other specialties, such as pathology and radiology, you need a concrete diagnosis. And as soon as you have that concrete diagnosis or you made a decision, like you said, it has massive flow on effects. And the other side of that is a misdiagnosis. And that
Mm.
misdiagnosis in patient's treatment pathway, if it's something catastrophic, even within 4 hours of that misdiagnosis and someone picking that up, can be almost a fatal event occurring. And sometimes it can be a
Mm.
misdiagnosis of not picking up that cancer cell or that cancer looking lump on an X-ray or on a CT. How do you deal with that type of stress in your job? And I guess
Yeah.
it's the Spider-Man line, with great power comes great responsibility, because you have your end pathology results, and that's what we read, and we go to the summary, and then we just take that as definitive, and now this kind of cascading treatment pathway has been set for a patient.
Yeah, no, that's a great question. And I think the first thing is like it's a different type of stress. So you need to have definitive decision making and stress that comes with it. Yeah, there is. The problem is as well, it's very black and white. It is, the moment you hit enter and you validate the report. So the report is what you ultimately write about, the cancer or the condition that you see. The moment you validate it, it is there forever. So if you do something at the bedside and you say something to the family or whatever, you say something to the patient, you're like, oh, actually, we'll take that back. This is what it was, and what I said before wasn't 100% correct. Like it's sort of like it's word of mouth. You can sort of go back, but the moment you write it and say it is there forever, you can't delete a report. It's officially a documented thing that will forever stay. And yes, that brings a lot of stress, but at the same time, compared to someone who's at the bedside or in the ICU, like you mentioned, or anesthetics or whatever, they have to make the decision on the spot. You can't, if you've got someone who's crashing or, their blood pressure suddenly drops, you have to make a decision on the spot. You can't say, actually, you know what, give me a second. I'm just going to go grab a coffee and I'm going to have a chat to one of the seniors. Do you guys just want to sit tight here? I'll be back in about 10 minutes. Like, you can't do that. In pathology, you can. And that's another great thing about pathology in that work day quality of life, I guess, is that if you've got a really tricky case, you can get up, And you can go to get a coffee and sit there for 10 minutes if you really want. And you can think about it and be like, what else am I missing? Or what can't I see here? And then you can go to your colleague who's very experienced and be like, what do you think about this? And you show them, they look under a microscope. So you do have the final say, and it does bring a lot of stress when you've got to validate it. But if you've got a supportive environment where you're working with a lot of experienced colleagues, you can take the time to step away from your microscope to get someone else to look at it. In fact, in a lot of units, pathology units, if there's a melanoma, particularly if it's a young person or it's one that looks, doesn't look as malignant as other melanomas can, you actually need to get someone else to look. Some units even have rules where even if it's a glaringly obvious melanoma, someone else has to have had a look at it before you can actually write it and validate that report. So there does come a lot of stress with that kind of stuff, but the temporal stress, so the ability to have to make a decision on the spot immediately, is not there. So it's a different kind of stress, but it is one that some people prefer to deal with and one that some don't. Like, people like to just sort of get a decision done and move on, whereas some people hate the ability to sit on it and sit on it and sit on it, because then you can take the time. And if you do give yourself that time, does it make it worse? Like, you just sit there and mull over the decision too much. But it is stressful, but, it has the advantage of being able to take your time with that stress and, exhaust all your options before hitting enter. But yeah, it can be tricky. And, that sometimes the moment you hit enter, you get a flood of calls from the clinicians who are like, are you sure? Like, we didn't see this. Like, maybe you've done this incorrectly. And that happens all the time. So, and then with the decisions that are, like you said, like 20%, 70%, 80%, at the end of the day, we'll have the greatest understanding of what something could be. And we'll try and represent that, 10% or 20% unsure aspect of the condition in our report. And we're like, this could be this and this and this in the correct clinical setting. So it then becomes sort of a holistic decision where you tell the clinician, like, does this look like condition X to you at the bedside? And they'll be like, yeah, it definitely does. And I'm like, look, I think it could be condition X as well. However, I don't have 100% proof in the tissue that I've received. But if it makes sense with what you've got, I think it's appropriate that we call it that. So it can become a little bit like that as well, those conditions which are just almost impossible to diagnose 100%.